Hello everybody, we warmly welcome you to our 17th seminar of the Aphasia CRE seminar series. I'm Michelle Attard, one of the co-facilitators of the series. I'd like to begin by acknowledging Indigenous elders, past, present and emerging, and pay respects to the traditional custodians of all the lands in which we meet today. Today we're very pleased to have Mr. Kelvin Hill presenting for us. Before the formal introduction, let's briefly cover some housekeeping. Please be patient with us and the technology today. Our apologies in advance if there are any disruptions to your viewing during the seminar. Occasionally some attendees join late. So to enhance everyone's Zoom experience, please ensure that your microphone and video stay turned off for the duration of the presentation. Please also minimise your Zoom gallery so that rather than seeing boxes with other people visible, you'll be able to view Kelvin's slides as best as possible. So the seminar is being recorded on Zoom and it will be available to access along with our past webinar videos via the website. So you can just click on the resources tab to access those. The videos are usually uploaded 1 to 2 weeks after each seminar. A final reminder that the CRE has developed a repository of aphasia-friendly COVID-19 resources. These have been sourced from across the world and you're welcome to use these resources in your practice. Questions for this seminar will be aided by the use of Slido. So you can log in anonymously or with your name and ask Kelvin a question. Our event code is Aphasia CRE. Enter your question under the Questions tab at any time throughout the presentation. You'll be able to see questions asked by other audience members, and you can like a question by clicking the thumbs up button to show which ones are of most interest. It's a great way to engage with the presentation experience, and there'll be plenty of time for questions in today's talk. Please also engage with us on social media via Twitter and Facebook. Feel free to tweet along today, and you can use the hashtag AphasiaCRE. If you haven't already done so, please join us as a member of the Aphasia CRE. We welcome everybody, people with aphasia, their family, friends, health professionals, researchers, and organisations to the Aphasia CRE community of practice. Benefits to community of practice members include a regular newsletter, updates about events and activities, contributions to research, networking opportunities, and more. Finally, the CRE is always looking for financial support, and if you wish to donate, please see our website for details. Now, I'm ever so delighted to introduce Mr. Kelvin Hill, our speaker for today. Kelvin graduated from a Bachelor of Applied Science in Physiotherapy in 1997 at the University of Sydney. And he's worked as a physiotherapist for several years. Since 2003, Kelvin has worked at the Stroke Foundation. He has developed a passion for improving services for people with stroke by implementing evidence-based care. Kelvin's current role is National Manager for Clinical Services, where he oversees the development and implementation of multiple initiatives, which we'll hear about today, particularly the Australian Stroke Guidelines. In addition, there's the National Stroke Audit and some other national clinical and policy activity. Thank you so much, Kelvin. Over to you. Your volume's not quite coming through.
Thank you. Is that better?
Oh, yes, perfect.
Excellent. And you can see my screen okay now?
It's just in presenter view, so you're nearly there.
How's that?
Fantastic.
Wonderful. Thank you for that lovely introduction, and thanks everyone for coming along and being interested in guidelines and the project that we're doing. It's been a pleasure working with the Aphasia CRE, a great group of people, and I think we're kicking some real goals, so it's very exciting. So I'm going to talk today about our Living Guidelines project and how it intersects with people with aphasia and the Aphasia CRE in particular. I just want to acknowledge some of the slides from my presentation today are from a colleague of mine from Norway, Per Van Vick, and I nicked some of his slides. So here's my disclosures. Obviously, I work for the Stroke Foundation. I will say very nice things about them. They're a good organisation, but I don't have any financial interests of the software that I'll talk about or anything else. So I'm going to start just with some assumptions. I'm going to start. I know we've got some consumers on the line, it seems, and I just want to touch on those assumptions. So one of the things that we've known now for many years and been evolving for at least, I'd say, 30 to 40 years is the notion that research ultimately improves patient care.
Sorry, Kelvin, we've just lost audio.
How's that?
Beautiful. Perhaps you could just start from the beginning around research improving patient care for us. That'll be lovely.
Thank you. Please jump in if I'm falling in and out of technology. So yeah, one of the assumptions that I make is that we know for a number of decades now that good research and quality research helps us to improve patient care. So that's why we do research.
It's happened again, I'm afraid. It seems to be automatically muting.
Yeah, my phone seems to just...
Sorry, Kelvin, that might have been a technical issue on my end, so I think you're right
good
now.
To know. All right, thank you.
All right, we'll get there.
Try again. So we know if you do research and quality research, and that tells you that certain interventions or diagnosis actually make a difference, then we know by collating that information and pooling the best available evidence will improve patient care. So we just take that as an assumption. We also know that there's wide variation in care. So data from audits and across the board, a range of projects has told us that while we know what research may tell us should be done, there is still quite a large variation from hospital to hospital, let alone state to state or country to country. So there's an underlying gap in care that continues to be a challenge. And we also know that there's a rapidly evolving evidence base. So there's lots of smart people that are on this call and others that continue to push and grow our knowledge through research, and that continually evolves. And what we know that growth in research has been exponential, so that there's more and more research being published, more and more information that clinicians, consumers, policymakers have to synthesize in order to make sense of what do we call best practice or evidence-based. So we've got a growth in research, we've got a continual wide gap in variation, and that's our challenge. So we need to ensure, obviously, that there's translation of what we know is the best evidence from research and make sure that's being done at the bedside with patients in all of our hospital settings and in the community wherever we provide patient care. So again, what we need to do in order to understand the evidence is to synthesize that in a systematic way. We need to have transparency about the assumptions that we've made in that process. We need to bring together the right people and process to make it trustworthy. And then we need to make sure that information, that advice is presented and available so that those that need it, be it the policymakers, busy clinicians, they can all access it in pretty much real time. Gone are the days where we publish a document, like the newspapers almost defunct now. Things that are printed are old news as soon as they get printed. So we've got some challenges, but we've also got some opportunities in the way that knowledge is shared across the globe now, and we're starting to tap into that. So the last couple of decades, there's obviously been a growth and advance in the standards and methods, not just for research, but for how we synthesize research, There's methods called GRADE, Cochrane, systematic review methodology. And we've come a long way, I think, since the 1990s to understand what is evidence-based medicine and what's best practice. We also have a similar growth in the methods that we do to collate as guidelines. So guidelines are one tool that we use to help evidence-based practice. There's multiple tools and guidelines are just one, but it differs from a systematic review because it collates not just the review and then it integrates into the system that you're trying to make recommendations for. So it conceptualises the evidence into your clinical setting. For us, this is an Australian setting, so we can take the evidence that's done overseas and apply it into our setting. So we know we've had great advances in the standards, methods, but we still have this challenge because we know that researchers have different silos to practitioners, to policymakers. So we still have this challenge with how do we efficiently or more efficiently move from the evidence through to practice to really get patient improvement. In the past, it's taken, I think there's studies to show that a seminal research paper could take years, 5 to 8 years to be fully implemented or impact clinical practice. And we really need to make that pathway much more efficient. So this is a conceptual framework some of you will be familiar with. This is the ecosystem, the evidence ecosystem. And if I just step around this, you can see at the top we've got synthesis of the evidence. So I'll just step backwards to the left-hand side. We obviously produce primary research. So that might be a new trial. It might be real-world data, collecting and analysing observational data, a range of myriad things that we produce evidence. We then have to synthesize that new evidence with the existing evidence to see what the whole body of evidence is. We then produce summaries or guidance to share that information. And then we want to see how do we implement or impact, what the impact of that is. And that gap should also drive new research to do that cycle all over again. We're fortunate now that we've got some really fundamental things that have gone on in the last couple of decades. We've digitised information now so that there's structured data, and that work's progressing and continuing, but we've got an ability to chunk information into bits of information that we can share much more easily. We've got common methods, which I've talked about. We've got processes and tools that enable this whole thing to happen, and hopefully we're building a culture of sharing and innovation. I think the Aphasia CRE sort of embodies this whole work in that way that we're working across different institutions, sectors, organisations, and trying to work smarter, not harder. And there's a number of great people involved, but also the processes that enable us to do that now. And here's an example of how the ecosystem actually can work rather than taking 5 to 8 years. This is an example from, again, my colleague in Norway. There was a number of seminal randomised control trials for PFO, so patent, forum and Avali closure, that were published in 2017, early 2018. That information was taken. There was an updated systematic review that was done fairly rapidly within 6 months, confirming the benefits overall. Previous to this, it was questionable. There was some doubt and the effects were not clear. So the additional research was synthesised. It became clear that there was a benefit within, again, only a matter of months, that the evidence and the guideline was disseminated. There was a HTA, because this is actually a tool or a piece of equipment that helps reduce the hole in your heart. It's a surgical procedure. So a HTA, which health technology assessment on this particular devices, was done. And then in Norway, they've got this wonderful system where the electronic health records plug straight in the evidence, and it's a nationwide system. So there was a field created for this specific indicator, and then they collected it, and that all happened within 12 to 18 months. So not just the systematic review, they've developed a guideline, they've embedded it in the system, and then they can really review and refine and drive improvement. So it's a lovely example of, the ecosystem actually working in a stroke-related context, and that's what we aim to do. So guidelines, as I said, is one tool that we have in evidence-based practice. Why do we need guidelines? Well, Tammy Hoffman, who some of you will know is an OT academic in Queensland, did a piece almost 10 years ago looking at the scatter of research. And just for, I think, neurology, I looked, the subset, to find all the RCTs, you had to search 180 different journals, or for the systematic reviews, you had to search 88 different journals. Now, we know that there's been a massive growth in publications and different journals, so that will be even worse now. So you can see busy clinicians simply have no chance to collate all of the relevant bits of information that they might need to collate. So that's one really important reason why guidelines and systematic reviews exist. The problem with the traditional guideline is that we do all this piece of work, pulling the information together, getting the experts together, making recommendations. But we know from some of my colleagues that you have new research being constantly published, and the recommendations are often out of date, sometimes months, but certainly within 3 years, this review found that 1 in 5 of the recommendations were out of date. So we need to do a little bit better in guidelines to make sure that there's not this this great amount of effort that just falls away because you stop doing the review and new evidence is published. For us in the stroke guidelines, we screened literally 110,000 abstracts. So for those who have done systematic reviews, you know the pain in that. So for a whole guideline, we screen 110,000. We're now screening approximately 400 a month. These are anything to do with stroke that's a randomised controlled trial or systematic review. So you can see on this next slide, the traditional guideline model has been this great growth of doing all the work and getting it current. So that's up to the top. But over time, once you stop doing your guideline update, there's new research, it loses currency as you implement and as time goes on, and then you redo your guideline or something changes, and then it drops off. So we know that there's problems with that approach. So the living approach really is to do all of the work, and then instead of the rapid drop off, pick up, drop off, we're just incrementally looking at the new published evidence, seeing how it impacts the guidelines or the evidence as a whole, and making modifications as we go along. So hopefully you can see that the currency and the reliability of this model we think is the way to go. And stroke has been a guinea pig, so to speak. We were probably the first truly living guideline for stroke, certainly in the world, but in Australia we're the first living guideline that started. We've sort of been overtaken by colleagues of mine. Diabetes guidelines have done that, but probably most of you are familiar with, hopefully are familiar with the COVID task force guidelines. So these are our national COVID guidelines, which are living because of obviously the growth of the COVID research, and they're doing weekly cycles. So if you think about doing systematic review every so often, they're doing weekly. In stroke, we're doing reviews on a monthly level, and that takes a lot of time and effort. So that's the basis behind the living model. For those who don't know, the guidelines is 2 years, just over 2 years now, 2.5 years into a 3-year, funded by the Australian government through the Medical Research Future Fund. It's been a lovely collaboration in partnership with Cochrane Australia, who have really been the leaders in testing models for living evidence. Cochrane obviously is a standout network of systematic reviews, very rigorous, but they know that actually doing a review takes time, and we need to make sure that the recommendations or the advice, the outcomes from Cochrane reviews are kept up to date. We've got in this project 90 experts from across the country, from across the multidisciplinary team, from ambulance officers right through to GPs back in the community. We've got importantly 28 consumers, or what I call lived experts, providing input into recommendations, practical considerations, and helping us decide which are the topics we should focus on with the guidelines. So the idea is that we dynamically update the evidence when the evidence changes, not waiting for a period of time. And as I said, we're the first of such project in the world, probably. And here you can see on my screen is the sort of the big project, that's sort of the model that we're trying to do, where we've got the funnel at the top and we've got new published research coming into the big cog of this evidence synthesis, which we do with a couple of softwares. Covenant is a systematic review tool, and Magic is our guideline publication development platform. So that everything that we do is online now. It's all digitized. There's no more hard copy guidelines. And we've got this great network of people who feed in their expertise to help us make sense of that evidence. And then we, are trying very hard to make that accessible wherever people need it to change practice and policy. And hopefully the clog continues. And as well as you can see on the right-hand side, when we know that there's a gap in research, that's when researchers like those online can do a piece of work and feed into the whole process. So we're hoping that as new evidence that gets developed through the CRE even can be rapidly integrated into our national guidelines rather than waiting years to do so. So just touching on the process, I'm not going to get bogged down in the process too much. We've got a small project team that helps identify, as I said, on a monthly level, anything that's published. We check this with our content experts who are allocated to each of the 90-odd clinical questions that we have in the guidelines. We then, if something is deemed to be impacting or potentially impacting the body of evidence or the recommendations, we'll rapidly review that, look at the grade profile or the way that the evidence is synthesised. We'll do that in collaboration with our clinical experts. And then we'll update what's called the grade profile or the evidence to decision framework. And we do this importantly with our consumers and our clinical experts. So our consumers are central in that they help us decide if something, what the values and preferences that they bring, and also what are the practical considerations that we need to inform clinicians about this topic. So just touching on what's changed, this model's been going for a few years now. It took us about 12, 18 months to get up and really running. But there's a number of changes that we have made based on new evidence. So there's been a number of thrombolysis. I won't touch on all these because it probably doesn't, relate too much to this group. But there's a number of medical changes that we've made, and recently with oxygen therapy targets, cholesterol targets. There's been a strength training recommendation that's recently been out for consultation, and shoulder pain. There's a number of updates that's being developed: walking, ADL, swallowing, sexuality, depression, memory care support, and importantly, the aphasia and apraxia of speech topics are also actively being reviewed at the moment. So not only does the evidence, the recommendations change, every month we obviously see if there's new evidence that helps tweak the background information, whether it's actually a summary of the evidence and there's a new trial that adds to the already existing evidence and doesn't change it. We make a note of that in the recommendations or in the background text. And we have a table in the living guidelines that informs what actually has changed, and you can see the link there. So moving on, how do we make sure that the recommendations or the evidence actually gets implemented? This is where the rubber hits the road. It's for those of you who do implementation, there's probably a number of you online. I'm not sure whether Emma Powell's online, but or others. Kirsten's been actively in helping us. But I have found, I'm really proud to say I've found the magic bullet for implementation. Here it is. Well, it actually doesn't help us with implementation, I'm afraid, but it is a magic bullet, apparently, and it helps with things. So it's actually not that helpful for us implementing practice. What we do know is that implementation of evidence into practice actually has a number of barriers. So this is some work that we did a couple of years ago, a survey of nationally, had about 300 people respond, and this is the word version of what the themes that came out. And obviously, time, resources, the awareness, a whole bunch of things influence the way that people absorb information at a clinical level and make changes at their local practice level, but also in the system-wide change, which can really impact on patient outcomes. So there isn't any magic bullet. We know that you need to contextualise the evidence, understand your local barriers. Not every health service is the same. Staff are different, processes are different, patients are different, and we need to consider all of those things as we do that. But just within a context of how does guidelines help us move from information in research through to practice, there's 4 sort of core areas that I think guidelines can provide a tremendous help with implementation. Obviously, to do so, we need to ensure that as I said, evidence to practice needs to be done systematically. It needs to be done in a transparent way, so you know what assumptions have been made or what decisions have been made as you pull that information together. Those online will probably no doubt have read one systematic review and looked at another systematic review on the similar or the same topic, and they come up with different conclusions. So there's nuances in the way that we do systematic reviews and the inclusions and the assumptions that we make that need to be transparent. Thirdly, we need to be accessible. So if you look at the current guidelines, and this is one of the recommendations for our aphasia based on the Brady-Cochrane review, you can see that it's systematic. I've touched on sort of some of the processes, but there's a proven methodology called the grade process where we have steps to follow. The literature identification process is systematic. It's been developed with my peers at Cochrane Australia. We're pretty confident it covers just about, I won't say 100%, but about 98% of all randomised control trials that are published we know about. It's transparent in that in Magic, you can actually click on each of the tabs. So you can see the middle circle in this slide. When you just see the recommendation, that's fine, but you can click on the research evidence and that will take you to the actual summary, and you can even drill down further to look at the way that we've graded each of the outcomes for that PICO. The evidence to decision framework that you can see here is the grade profile. It gives you a summary of the benefits, harms, certainty, preferences and values, and resources, so any of the economic implications. We have a rationale that gives a snapshot of why the recommendation's made, any practical information, and a new tool about decision aids, which we hope to be used more and more. So you can see that the guideline and information is accessible. It's accessible over multiple layers. If you want to drill right down, you can. If you just want the top level information, you can just see the recommendations, the strength of the recommendations, and the information that's relevant. But it is a systematic process. Going online and using these tools is transparent. I think that is useful. And finally, we need to have it needs to be trustworthy. And again, we need to develop these with good people, so experts who know their stuff and have good processes to follow and implement. So the people on the screen are all the speech pathologists across the country who are involved. Some of them are involved in the swallowing topics, but the majority of them are involved in the communication section of our guidelines. So just a big thank you to all those people who are involved, which is just fantastic. So we have some great people who are involved, and that should bring most of the people online will know several, if not all, of these people. A big heads up and a thank you to Erin Gadecki, who's been leading this group. She's just taken a break, and Rachel Wenke is taken over as the lead of the speechy group, so that's fantastic, and looking forward to working with her as well. So just more in thinking about the process, importantly, we have the opportunity, having the right people together, linking the CRE with the guidelines is to ensure that there's collaboration. So Miranda Rose, who I know is online, hi Miranda, has been fantastic in leading the CRE and in linking the relevant people and organisations in. So from our point of view, it's really important that the evidence synthesis is done hand in hand with what is being used, for example, in the aphasia pathway. So the intervention advice being provided is going to be similar, if not the same, to what we'll have in the clinical guidelines moving forward. And I think that consistency is, and sharing of resources both ways is really helpful, not just for the guidelines but for the pathway and other tools and resources that spin off guidelines. So that's really important. So finally, will the guidelines being living make any impact? Will it change the way you as clinicians view guidelines? I'm not exactly sure. We're doing an evaluation at the moment, looking at the feasibility, transferability and initial impact of that work. And some of you may have filled in a survey recently. This again is a survey that we completed 2 years ago, and we asked, as we started this journey, is moving to living likely to impact the way that you view the guidelines or use the guidelines? And we certainly saw, for those that completed that survey, that there was an increase. And I'm hoping that the evaluation will have demonstrate the same thing. I think anecdotally that is the case, and I think there's a lot of goodwill, but also excitement across the clinical community, people I talk to who value the notion that this work is going on. There's a group of people that are inputting, and we're making sure that the advice that we provide is timely and incorporates all the best evidence. So, in summary, I knew I'd be quick. Look at that. Fantastic time for discussion. We know that evidence-based practice does maximise patient outcomes. And it's really important that as clinicians, we are aware of the evidence, we integrate it into our daily practice, we integrate it into our pathways, our departments, the way that we do things to ensure that we're providing the best care to the patients and maximising their outcomes. Guidelines, as I said, is one tool, but it's an important tool in our Australian context that informs practice and helps that transition from evidence through to practice. We should be very proud that we are the leaders with Cochrane Australia leading the way, and ourselves in stroke and others now taking up the notion of doing this more rapidly and providing really sound advice much quicker. And it's been really a great demonstration that we're working smarter and not harder, and that's a really important message from the CRE as well, that we utilise the work that we're doing concurrently and build on each other's shoulders to get the most that we can out of the resources that we have. If you don't know and you want to find out about the stroke guidelines, Inform Me is the clinical website, informme.org.au. You can click on the guidelines, it takes you to the link which directly goes to the Magic platform. The Living Guidelines update gives you the updates of where we're up to, what's changed. For the consumers who might be listening in, this information importantly does get reflected in the Enable Me website. We are trying to do some work and we'll be doing a bit more work next year to ensure that the information that's changed or the advice that's changed to clinicians is also communicated in a relevant format to consumers. And that will happen through Enable Me, which is our sister platform for consumers, and other resources that hopefully will get developed in that process. And I'm going to stop.
Thank you so much, Kelvin. We're just about to jump over to our question and answer section of the talk now.
Was there any, I haven't been looking at the chat, but was anyone, any of those chats we need to respond to?
I've pulled them up.
You have?
Slido screen. So as that opens up on your computer, we'll be able to address them there. Thank you. Okay, so just bear with us as that loads.
Hopefully.
Is that showing up perhaps on a different screen?
It might be. Let me just get it out here. Yeah, okay. I'll just move this over here. Can you see that now?
Just give it a minute.
Or can you just see my Outlook?
No, we're seeing your PowerPoint.
The PowerPoint. Okay. Let me just swap a minute.
Thank you.
Try again.
Fabulous. Here we go. Okay, so thank you everybody for contributing those questions we see here. I'll take us through them and you're welcome to continue adding more as we go. So Annabelle asks, is the survey that you mentioned with the word cloud where you talked about evidence-based evidence practice gap, is that survey published and are we able to access those findings somewhere? Thank you.
Good question. It was part of was one component of a larger piece of work looking at where clinicians find evidence and what the role of Inform Me is. I'm very happy to share that information or a slide deck with that information if you'd like. We haven't published that. It was mainly for project development, but happy to share that if whatever. Annabelle, you can contact me and I'm happy to share that.
Okay, great. Thank you. Annabelle says thank you. Our CRE director, Miranda's asked or commented, the living guidelines are an incredible advancement. Huge congratulations to you, Kelvin. Are other international stroke peak bodies following your lead here?
Yeah, it's a good question. I've been working with my peers in stroke guidelines for over 10 years. So we met up, I think, in 2005, 2006, to try and work smarter together. We have a good relationship with the other guideline developers, you know, whether it's the Canadian best practice guidelines or whether it's the UK. We've never really managed to get a proper international collaboration to make this smarter. Clearly over that last 15 years, we've had a growth of methods and platforms, and I think we're at a place now where we can certainly share and work more collaboratively. No one else is doing a living model like we are. I know the Canadian update their guidelines every couple of years, which is what the UK tried to do as well. But again, it's a different model. You still have to got that ramp up, down, and hopefully we'll demonstrate in this project that just that month-by-month review of the evidence is more efficient and more sustainable overall. So I'm hoping that other international groups will pick up and work with us on this. I mean, I recently had a meeting. We had a meeting with the European Stroke Guidelines group, who are just starting to use Magic as a platform. They use grades, so there's some nice things to do, but they've been historically very medical focused. So it's just identifying where there's opportunities and working smarter. Good question.
Right, okay, we've got a question here. Incredible to hear of the level of detail present in the guidelines, and great to know that the process was co-constructed by health professionals as well as consumers. Can you describe the process of engagement in a bit more detail? And just link to that, Kelvin, a question, a couple of points down there. Are people with aphasia represented within the group of contributing?
So yes, we do have people with aphasia and carers of aphasia in the group. The model of engaging with our consumers has been iterative. Obviously, as an organisation, we're very strongly grounded in consumers, and we have a consumer council that feeds into our board, so at a strategic level. At the start of this process, I sat down with the chair of that consumer council, and we said, we're doing this piece of work. How do we ensure that consumers voice is even stronger. And we mapped out and we talked to the Consumer Council and some of the other sort of experts who have been involved with consumer work. And we came up with this model of having not just, a few people involved, but actually a whole panel of experiences from right across the country. So that was instrumental, getting their advice as to the best model to set it up and to test it, and we hope to refine it. So Annie Sinnott is someone who works with Cochrane Australia. Some of you probably know Annie. She's doing some work in part of her PhD to sort of map out how do we deepen the engagement with consumers within guidelines, but within evidence-based practice as a whole. And I'm looking forward to seeing her work and seeing what we can learn further, what's been published, but also sharing our experience. I think there's been this quite a nice growth and recognition right across the globe of the importance that consumers bring to informing advice that we give as health professionals or receive as health professionals. So it's important that they're at the table in those discussions and also helping us identify where there's gaps in practice. So I remember a couple of cycles ago, one of my dear friends, Brenda Booth, who's probably many of you would know too, as a stroke survivor, she said, well, why isn't there any advice around fatigue? And we didn't have a topic on fatigue, and her recommendation brought in a whole topic on fatigue, which didn't have a lot of evidence back then. That's evolved, but it was really important recognition from her, and we changed our guideline in response to that. So the model's been iterative. It's been got advice from consumers themselves, but experts in consumer engagement, and that's been sort of the process to this time.
And that's just incredible, given the number of people involved and different groups involved, that you were able to sort of complete that major process within about 18 months, I think you were saying. Fantastic.
Yeah, we can always do more, and it's, the whole working hand in hand with consumers is so important, and it takes time. Fortunately, we had some very good engagement that had been involved previously, so it sort of expedited the process.
Yeah.
But yeah, it's been a great example, I think.
Brilliant. Miranda, again, obviously the guidelines are only as good as the available evidence and the PICOs that are asked, so the population intervention, comparison and outcome. Can you explain a bit about how these PICOs are developed and prioritised?
Sure. Good. Miranda's on fire. Look at all the questions she's banging at me. Like I'm left enough time. So, good question. PICOs, obviously this is the 2017 guidelines was the 4th update for our national guidelines. So there's been a long history with us looking at what topics that we need to include, engaging with various stakeholders to identify and prioritise those things. We did go through a process between 2010 version and 2017 where we rationalised because we had fairly limited resources to do the update. So we dropped a few topics. But the process now with PICOs is every year. So annually, we'll review the topics that are included in the guidelines. We send out to our working groups, including our consumers, a list of topics, asking them to review the topics, identify if there's gaps that we would like to focus or emerging evidence that we should provide advice on. And we, at a topic level, get advice from the multidisciplinary team. So we have a steering group which has the lead of the various craft groups involved. They came together just earlier this week to do the discussion of this year's review. And we actually decided to bring in a couple of the old topics that we didn't do. Sleep quality and sleep apnea is one topic that we'd like to revisit. So it's an iterative process of reviewing from those involved, but also we have a process where on our website, if people can either send me directly or the team or suggest new topics, and that gets considered each year as we review the PICOs. Obviously, PICOs take a little bit of time, as those Miranda well knows, to do a systematic review. You need to be really clear what your PICO is. And for those who PICO's, if it's PICO's forum, this is just the way that we define what the clinical question we want answered from the evidence. So it's looking at the patient, the interventions, the comparisons, and the outcomes. So it's been an iterative process. And hopefully that answers that. Now she's asked another one.
Great. Yeah, you're handling all these curly questions beautifully. She's following on from that with a great question for all those lovers of qualitative research out there. How is evidence from qualitative investigations handled in the PICO, and evidence harvesting or grading processes managed for the guidelines?
Excellent question. So we know that there's aphasia research, for example, historically hasn't been the big randomized control trials that really has utilised different research methods. Historically, we have searched for the hierarchy of evidence for each topic. So we've looked at if there's a systematic review for interventions from RCTs, we'll just focus on that highest level of information. We will look at some of the other information, the qualitative information, as we sort of scope out and introduce topics, so to speak. So what I call in the preamble, introduction, to give the sort of some of the background, incidence, prevalence, some of the issues, some of the patient-related factors for each topic. But from the guidelines point of view, we've needed to really, with the process and the resources that we've had to really focus on interventions and look at the highest quality that we can get our hands on. So there is a process. So I'm skirting around the question, you can see here, Miranda. In the past, we have just focused on quantitative research. We haven't really fully integrated qualitative. We recognise that that would be the ideal model. We've touched on it, as I said, a little bit on the side. There is a process within GRADE, as you well know, that you can review qualitative information, observational data, and there's some decision rules about upgrading, downgrading that information. As a rule of thumb, though, we've been really focused on interventions and looking at the sort of highest level of information. So if there's RCTs or even non-RCTs, but intervention designs, we'll focus on those things before searching beyond that with qualitative research. It's probably, we've moved on, I think, and the growth of research has meant that we're a little bit more picky now. So we probably don't have to go down to those lower levels, even though they have their place. But yeah, just for resources, we don't fully integrate qualitative work as much as we would like. And it's really up to each individual case and those clinicians involved in that topic to frame and to include the relevant information over and above our interventions.
Bravely tackled, Kelvin, and it's nice to know we're eventually heading towards that ideal. Next question here. It's great to see all the engagement following your talk. How do you anticipate that we could shave off a few more years, likely what will be the larger chunk, in linking the living guidelines content to actually mediating the barriers to implementation in practice?
Great question.
Solve all our problems, Kelvin.
Look, if I could do that, I mean, I've been working in this space for over 15 years now, and I think, as I said, guidelines are just one small and important piece of the jigsaw puzzle. I think we need to think system-wide. We need to think strategically. We know that there's still evolving evidence around implementation science. What are the best things to do? There's been a whole growth, obviously, about the magic bullets that don't exist, but framing it and systematizing it so that we're identifying what are the real barriers, not just what we think are the barriers, so that we're really tailoring the strategies to be more effective. I think we've got a long way to go. You know, the fundamental building blocks that we've done as a Stroke Foundation is defining what best practice is, so identifying and just having that information as guidelines, conducting an audit to enable sort of an understanding of the adherence in clinical practice, and I think the importance of data collection or monitoring care, and then tools, resources, education, right through to systems redesign. All of those things play a part, and as I said, that's why it needs to be contextualised, and there isn't any magic bullet. We have done some work just trying to identify, can we focus our attention on a few key things that we really put a bit more effort in with implementation? That's taken a long time to even develop a priority criteria, prioritise it, and now we're getting to the place where we're actually developing some strategies, looking at what's been published as working or hasn't worked, mapping to a framework. So, it's another whole step. But you're right, it all takes time.
We'll cut you some slack then, Kelvin. Good.
There's some great people working in this space, and some great people around the Aphasia CRE is doing some important work in this space as well. So I think we're all trying to work smarter in this. What does work and what doesn't.
Absolutely. Okay, so we're rounding towards the end of our questions now. If you're happy to plough on, we have a question or a comment saying, thank you for this outline. It's such a valuable resource. As you say, there is also a guideline for COVID-19. I'd love to access one for other types of disability. Do you know if there are any other living guidelines for the disability sector or plans to fund any?
Great question. So we're actually part of a group of like-minded organisations. So there's actually a living evidence consortium or a network of organisations. So Stroke Foundations being stroke, diabetes is another one, Heart Foundation's involved, we've got musculoskeletal and kidney health. So more targeting high burden diseases, but you're right, this model does relate not just to disease groups, it does relate to other broader sectors. There are guidelines, I know, for non-health related, so in the disability sector, not as widely sort of resourced. The evidence base is obviously a bit trickier as it further along you go in different types of models, so it makes analysis a bit more complicated. But yeah, there is a growing awareness at a government level as well that we need to keep our advice current, and we've been the Alliance has been advocating for governments federally and across the states to pool some resources to make sure this continues at a national level for at least our diseases, and then expand over time.
Okay, great. Have you had any feedback regarding consultation or implementation of the guidelines in practice across healthcare settings?
That's a good question too. Not a lot of feedback personally. I'm interested to hear people online, whether there's comments in particular. We know that not just acute, so hospital people or clinicians, stakeholders access the guidelines quite a bit. That's where we focus. The community sector does access it as well, and different groups. So it is being used across the continuum. We have sort of that Google Analytics data of who accesses the information, but how much they're actually implementing, using, we don't have great information. Part of the evaluation will try and capture some of that, but particularly the community-based long-term care, we really have poor data sources, and it'd be great to do some work about how that's occurring across Australia, not just for stroke, but for other diseases.
Yeah, that sounds good. We have a sort of linked question here from Bianca. Firstly, as a current student and a future speech pathologist, I really appreciate the incredible level of effort and detail that goes into this living guideline. Are the guidelines externally reviewed by experts? Great
question again. So there's checks and balances across the whole system. Obviously, there's the internal process. We've got a small working group. We then get the wider working group, and then the full multidisciplinary team to review before it even goes out for public consultation. So it does go out for open consultation right across the country. inviting anyone to provide comments. The NHMRC, who we submit this guideline to approve, they do their own external review. So they get experts for the topics that we've gone out to review that content and give them advice to make sure that the recommendations have been developed, do align with what the evidence says. We haven't misinterpreted it. So there is multiple checks and balances in that peer review process.
Fantastic. Well, thank you so much. That's the end of our question and answers. I really appreciate your generosity of time today, Kelvin, and we'll just pop on our lucky last slide here. Okay, so audience members, if you have a moment, please provide future feedback for ongoing seminars via the Slido app under the polls tab. And I'm sure you all join me in thanking Kelvin for this wonderful presentation. And we're all very keen to go and have a look at the guideline, I imagine. So that's it for our seminar series for 2020. Our team is really proud to have collaborated with 17 brilliant speakers over the life of the seminar series to date. So thank you to everybody who's been involved, either as a speaker or an audience member. Thank you to my co-facilitators, Caroline Baker and Kelly Maskell as well. We look forward to recommencing the seminar series in February of next year, where we'll be excited to have Dr. Anna Volkmar from City University London presenting. Her talk is entitled The 3 Variants of Primary Progressive Aphasia. What are they and what helps? So we'll see you at the end of February for that one. Thank you again, everyone. Best wishes and see you next year.